this video, we will be going over the pathophysiology of peptic ulcer disease and the treatments used to protect and heal the ulcerated GI mucosa. So there's a lot of overlap between the pathophysiology of GERD and peptic ulcer disease, and you will notice a lot of commonalities as we go through this topic and the treatments. So the GI tract is composed of 4 foundational layers that are specialized based on the function of that particular organ that we're talking about. And for this video, that will be the stomach and the most proximal portion of the small intestines. The layer we will be focusing on today will be the mucosa, which remember is the nearest layer to the GI lumen. So the mucosa is the one that includes those specialized epithelial cells lining the lumen. And remember, these are the cells that are going to secrete the gastric acid in the stomach, the various kinds of GI hormones, and most importantly for today, these will be the cells that are secreting mucus and bicarb to protect the mucosa in the stomach and the most proximal part of the duodenum. So under normal physiologic conditions, the mucosa of the stomach and the duodenum are protected from this caustic environment necessary for digestion because of these specialized epithelial cells. Or the mucus cells that, remember, are the ones that are secreting the mucus and the bicarb, forming this protective layer and the pH gradient. However, if these protective factors are compromised, then peptic ulcer disease results, where this is also an acid-related injury, just like with GERD, but now it involves ulceration of the mucosa, typically going all the way through to the last layer of the mucosa. And as I've alluded to, this can occur in either the stomach or the very proximal part of the duodenum of the small intestine. So there are 2 common etiologies we will go over today, being NSAID-induced peptic ulcer disease and Helicobacter pylori or H. pylori positive peptic ulcer disease. And once these ulcers occur, they need protection from further exposure to that gastric acid in order to heal. So think about how we might protect these ulcers with treatments as we go through the causes in more detail. So moving to the next slide. So starting with NSAID-induced ulcers, and NSAID stands for non-steroidal anti-inflammatory drugs. But before we can go over how NSAIDs cause peptic ulcer disease, we first need to discuss the arachidonic acid pathway and prostaglandin synthesis first. So the arachidonic acid pathway is important for the synthesis of eicosanoids, which are generally thought of for their inflammomodulatory effects, and they include prostaglandins, which we'll focus on today, thromboxanes, and leukotrienes. So this pathway begins with the membrane phospholipids. And these are converted to arachidonic acid and other polyunsaturated fatty acids by phospholipase A2. Arachidonic acid is then converted to PGG2 by cyclooxygenase enzymes, which are also known as COX-1 or COX-2. Now, one important thing to note is COX-1 is constitutively expressed on platelets, GI mucosal cells, and renal tubular cells, whereas COX-2 is inducible at sites of inflammation. And we will revisit these enzymes in just a second. So once we have PGG2, after a series of other reactions, we will end up with PGE2 or PGI2. And PGI2 is also known as prostacyclin. And these 2 prostaglandins in the GI tract can act upon the prostaglandin E receptor 3 or EP3 receptors, as well as EP4 receptors, triggering a slew of cytoprotective effects, like a reduction in gastric acid secretion in the stomach and increased mucus and bicarb secretion in both the stomach and the duodenum. Now, in the case of patients taking chronic NSAIDs like ibuprofen and naproxen or aspirin, these agents all exert their anti-inflammatory effects non-selectively inhibiting COX enzymes, so COX-1 and COX-2, and the downstream production of prostaglandins and other pro-inflammatory molecules. So remember, COX-2 is the one that is inducible at sites of inflammation. So if you have knee pain and take an NSAID, it will reduce the pain and inflammation by inhibiting COX-2. However, because they are non-selective, they are also going to inhibit those COX-1 enzymes that are constitutively expressed in several locations, one being the GI mucosa. So even though we have alleviated the knee pain, we are inhibiting the cytoprotective action of prostaglandins in the GI tract. So we end up with more acid and less mucus and bicarb, eventually eroding away this protective layer, exposing the mucosa to gastric acid and eventually leading to ulcer formation. So this is the greatest concern with NSAIDs being available over the counter, because this gives the illusion that they come without risks. So for a patient presenting with peptic ulcer disease and NSAID use, the first course of action is to discontinue the NSAID. Alternatively, if the patient must remain on an NSAID in the future, the recommendation would be to switch to another agent outside of this class of agents, or to switch to celecoxib, which is a COX-2 selective agent to preserve this COX-1 function in the gut. So now that we have discontinued the offending agent, there are several treatment options you should be aware of, but you already have probably guessed by now the best way to protect the ulcer would be to reduce gastric acid levels, just like with GERD. And PPIs, or proton pump inhibitors, are first line for peptic ulcer disease. But now, instead of just once daily dosing, they are dosed twice daily, which is sometimes called intensive PPI therapy, because we need to heal this ulcer, instead of just preventing future esophageal erosion like with GERD. And remember, our newer PCABs can also be an additional acid-suppressing therapeutic option in place of a PPI here. So moving forward on these schematics, you'll just see PPI, but remember a PCAB can be subbed in as well. H2RAs can occasionally come into this picture, but again, we need effective and pretty complete inhibition, which remember H2RAs have some concern and PPIs are generally more effective. The next agent we're going to talk about is misoprostol, which is honestly pretty uncommon and kind of like cimetidine was with GERD, not really used for this indication, but more used for other indications related to its off-target effects. So misoprostol, or Cytotec, is a prostaglandin analog. And the thought was it would be a prostaglandin supplement to help support activation at these prostaglandin receptors and promote these downstream cytoprotective effects. Endogenous prostaglandins have a really short half-life, but misoprostol has a much longer half-life than the endogenous molecules. So it can actually hang around long enough to reach the site of action, but it is still pretty short and is going to require 4 times daily dosing. And this is one of the main reasons it isn't used for treatment very often, because again, we need that effective and consistent ulcer protection, and 4 times daily dosing leads to a lot of compliance concerns. Sometimes misoprostol is still used to prevent ulcers in patients that do need to stay on NSAIDs long term. So another agent that protects vulnerable tissue from gastric acid is sucralfate. And sucralfate is an octasulfate of sucrose. And in an acidic environment, it will undergo extensive cross-linking to produce a very viscous polymer that will actually adhere to the ulcerated tissue for up to 6 hours. And it may even stimulate prostaglandin synthesis and other factors involved in tissue healing. So because it needs acid to be activated, sucralfate, just like PPIs, has to be given before meals, so that it can reach the ulcer first and then be polymerized for protection. And because of this polymerization and its structure being huge even before polymerization, it isn't really absorbed, which makes it relatively safe. But just like antacids, it will bind drugs and prevent their absorption, so they have to be separated. But because we have PPIs that are very effective, this agent isn't really seen that much either. So moving to the next slide. So the take-home message is for NSAID-induced peptic ulcer disease. So primarily we need to stop the offending NSAID and avoid future use if possible, and this is key. along with a proton pump inhibitor to protect that ulcerated tissue during healing, or some kind of acid suppressing therapy like a PCAB, for instance. And then if future NSAID use must continue, they should be switched to either a COX-2 selective agent, continue their PPI use, or the addition of misoprostol may be warranted. So now let's move on to our second cause of peptic ulcer disease, being H. pylori, and how this is addressed from a pharmacologic perspective. So moving to the next slide, let's talk about Helicobacter pylori, or the H. pylori organism first. So H. pylori is a gram-negative rod bacteria that has several virulence factors that aid in its ability to colonize the GI mucosa, leading to ulcer formation. So first is the flagella, mediating motility through these layers to reach that epithelial layer. Second is the expression of urease, which cleaves urea into ammonia and carbon dioxide, which can neutralize the gastric acid, promoting a better environment for H. pylori survival. Next is the lipopolysaccharides on the surface of the organism, which allows its adherence to the epithelial cells of the mucosal layer. Once adherent, the ammonia can cause mucosal injury, or the H. pylori organism can inject its effector molecule, known as CAG-A, or cytotoxin-associated antigen A, into the epithelial cells to damage tight junctions and induce the production of IL-8, or interleukin-8, which allows for the chemotaxis and the promotion of inflammation of immune cells, damaging these regions of the mucosal lining. H. pylori can also release its exotoxin, known as VAC-A, and this is short for vacuolating cytotoxin A, can be internalized into the epithelial cells, and then can travel to their mitochondria to form pores and destroy that membrane potential, triggering apoptosis. Together, these insults lead to a loss of epithelial cells that are functional, and therefore a loss of protective factors. So in addition to bacterial colonization and mucosal injury, now there is also acid exposure, leading to that ulcer formation. So now moving on to the treatments of this form of peptic ulcer disease. And just as before, we still need to protect that ulcerated mucosa from gastric acid exposure while it heals. So PPIs are going to be needed, or one of our newer PCABs. And then just as before, all the schematics moving forward are just going to list PPIs, but again, those PCABs can be subbed in their place. And then we do need to remove that offending agent again, or in this case, we need to eradicate the H. pylori infection. As you might expect, this will involve antibiotic regimens. So we are going to save the detail of the mechanism of actions, adverse drug reactions, and counseling points for infectious disease later on. But right now, we're just going to briefly go over the mechanisms of each of the antibiotics used to treat H. pylori. So the first line regimen recommended is what's called triple therapy. So this will be a PPI, like we talked about, and two different antibiotics. So the first is going to be clarithromycin. And this is a macrolide antibiotic, which binds to the 50S ribosomal subunit, thereby inhibiting protein synthesis in the bacteria. This is what's known as a bacteriostatic antibiotic, meaning that it prevents further growth of the bacteria. The second antibiotic that is usually used in this triple therapy is amoxicillin. Which is a beta-lactam antibiotic that binds penicillin-binding protein, which is necessary for the cross-linking process that is involved in cell wall synthesis. So without a functional cell wall, the bacteria will be unable to survive. So these direct killing effects make amoxicillin bactericidal. In individuals that are allergic to penicillin, metronidazole is used in place of amoxicillin in this triple regimen. So metronidazole is also a bactericidal agent because it is taken up into the bacteria to form cytotoxic metabolites, which can then interact with and damage DNA, triggering cell death. So together, a PPI, clarithromycin, and amoxicillin or metronidazole are first line. But if for any reason this therapy fails to eradicate the H. pylori infection, we move to quadruple therapy, which will still include a proton pump inhibitor and now metronidazole. But also we're going to add in tetracycline and bismuth. Sometimes clarithromycin resistance is the reason for treatment failure, so we can use tetracycline in these cases to still inhibit protein synthesis, but by now binding the 30S ribosomal subunit in bacteria. So tetracycline is also going to be a bacteriostatic agent because, again, we are not directly killing the bacteria. So now bismuth. So bismuth can come in two different forms. One is subsalicylate, which is the bismuth subsalicylate that is in Pepto-Bismol, or subcitrate. And the exact mechanism of action of this agent is somewhat unknown, but it has been found to have direct antimicrobial properties. It can form bismuth mucin complexes to protect the epithelial cells and can also stimulate PGE2 synthesis to ramp up those protective factors again. So this would be what quadruple therapy option would look like. Another regimen option that can be used if a patient fails initial therapy is, again, a proton pump inhibitor, amoxicillin, and a fluoroquinolone like levofloxacin. Levofloxacin and other fluoroquinolones are bactericidal agents that interfere with DNA synthesis by inhibiting topoisomerase enzymes. So just like metronidazole, just by a different mechanism, can induce DNA damage and cell death. These different combinations and regimens are almost always the combinations that you're going to see, but there are some different combinations of these same antibiotics that may come up, but they're generally not commonly seen. So if we move to the next slide. So the take-home message for H. pylori positive peptic ulcer disease is still acid suppression therapy first, along with antibiotic therapies to remove that offending microorganism. And most, not all, but most regimens will include a bacteriostatic antibiotic to stop growth in the meantime, and a bactericidal antibiotic to directly cause bacterial cell death. The treatment of peptic ulcer disease will require in-depth patient counseling to ensure the ulcer is protected from gastric acid. For example, the proton pump inhibitor needs to be given 30 minutes before meals, like we talked about in the GERD video. And the patient will need to understand why taking and finishing the course of antibiotics or avoiding NSAIDs is so important. And always being aware of patient expectations with costs is important. So it may not be as simple as switching the patient to a COX-2 selective agent because insurance won't cover it for their pain. Or the patient may not be able to afford the fancy combination packs for the H. pylori treatments like PrevPack and Helidec, but you could easily just write for the generic separately and it will be much cheaper than one fancy H. pylori treatment pack. So having these kinds of conversations is important to ensure optimal patient care once the patient leaves your office to go pick up their prescriptions.